Thank you so much. As Heather said, I'm Dr. Jeremy Wigginton. I'm Chief Medical Officer for Capital Blue Cross. We are based in the central Pennsylvania region out of Harrisburg, Pennsylvania. So if you're not familiar with Capital, happy to have you. And thanks so much to everybody joining. Today, we're going to be really talking about some key evolving trends with employer benefits in the self-funded health plan space. I have been working with self-funded health plans for many years. I am trained as a family medicine physician, but I've been working with self-funded employers for many years, looking at key clinical trends in the market and really how can choices be made to better serve their employees and members, as well as keeping up with medical trends and those complex issues that are occurring out there. Today, we're really going to talk about three topics that have been a lot in the media, but I have also talked a lot to employers over the years about these topics, so get a lot of questions on these things, particularly around weight management, GLP-1 therapies, gene and cell therapies, and then also there's been a lot of talk recently about the growing attention on gender affirming care. So we're going to take some time to walk through these three topics today, and I really want to point out some key things that I think are important for employers that have a self-funded health plan to take away from these topics. So hopefully today you will be able to leave with some good insights that may help you as you're looking at your own benefit structures. So just a little bit of my background, again, in disclosure here. I am board certified in family medicine. I am NAHU self-funded certified. I'm also a Lean Six Sigma black belt. I have a healthcare quality certification, a business degree as well. But I have no financial or professional conflicts of interest to any of these topics. I am employed full-time by Capital Blue Cross, and I have no relationships with any pharmaceutical or other benefit entities, no brokerages or other organizations. So just wanted to point that out. This is purely informational today. So let's start talking about weight management. I do want to talk a little bit about the market review of what treatments are out there, what those standards are, and then how self-funded health plans can look at plan benefit support for their members and employees. So looking in Pennsylvania, I know you're probably not all in Pennsylvania, but I do tend to kind of start with state-specific information. So many states in the Northeast kind of have similar metrics. But in Pennsylvania specifically, we have about 33% of adults and about 18% of children that have obesity. That means a body mass index of over 30. And if you look at how much of Pennsylvania is actually overweight, so that's a BMI of only 26. That's a pretty low BMI. I can tell you my BMI is over 26. So many people fall into the category in America of overweight. And if you look at that category, that reaches 65% of adults being overweight in Pennsylvania and 40+% of children that are likely overweight in Pennsylvania. And like I said, many of the Northeastern states carry those same kind of population statistics. In Pennsylvania, that's still about 10% lower than the national average, but it's still a very large segment of the population. I came from the Mississippi, Louisiana region. Initially, we did have a slightly higher percentage in that local region, but pretty much in America, there is quite a significant rate of obesity and overweight people. So today in the market, nationally, obesity can be thought of in terms of disease treatment options really in three core categories. One is lifestyle and behavioral change. That includes your things like diet, exercise, re-education. We, of course, have bariatric surgery that was quite predominant in the market starting about 15, 20 years ago. Some of those surgeries have evolved since the time that they really became more predominant in the medical community. But now we primarily have the sleeve gastrectomy, or known as the sleeve or sleeve surgery, and then gastric bypass, or the Roux-en-Y gastric bypass. Those are still predominantly the bariatric surgeries being performed in our markets today. We've also had this big growth of pharmaceuticals is adding to this obesity treatment option lineup. So we've had the emergence of Wegovy, which is a GLP-1, Saxenda, also a GLP-1, and Zepbound, which has some dual action GLP-1 and some additional action, but really kind of based around the same mechanisms of action. And these are in addition to those medications that we've probably all heard about for years, including phentermine, which was a component of a drug that came out some time ago called fen-phen. Some of you may remember when fen-phen was big in the market. But there's also medications like Contrave, Orlistat, and Qsymia, among some others that have been indicated to help people lose weight. So now we kind of have this three-prong approach in the clinical realm to looking at obesity. But in Pennsylvania specifically, you can see that it does affect industry. And I know we've probably all heard about the GLP-1 boom. I know we are seeing it on social media. We're seeing it on television. We're hearing people talk about it. When you go to your regular provider, they may be bringing it up as a part of treatment regimens for diabetes, but also for those that are overweight. And we really think the GLP-1 boom, or why there's this major focus on GLP-1s all of a sudden, really is a combination of, yes, there is true clinical need for us to address obesity as a nation and as individual states. Yes, the GLP-1s have clinical benefits for a key part of the population, but marketing has also had a major part in this equation of why GLP-1s have become so important, or so important to people and so predominant. And that does include social media. There has been a lot of information being presented via social media. And anytime you have a new drug that comes to market, typically that's always going to drive consumerism, because in America, drug companies spend a lot of money on marketing new therapies. There's commercials on television, there's direct-to-consumer marketing, there's marketing through providers' offices, there's posters. And so marketing really gets hit very hard when a new drug comes to market. So a lot of these things have really driven the very rapid growth and the popularity of GLP-1s, not only for diabetes, but also for weight loss. And so that tends to be the drug that comes to our mind when we think about what are we doing today to treat obesity. And I just want to point out that most information out there today, the most comprehensive information around obesity at the state level and at the population level actually comes from drug companies. So you can see that Novo Nordisk has put out some quite extensive data and aggregated data that much of it is very useful for Pennsylvania particularly. And I think that if you follow that link in the website, you can actually look up individual states and see what those metrics are. So we can see that they have aggregated great data that shows the possible impact of obesity on our workforce particularly. So again, really looking at what exists today in terms of obesity therapies, we have lifestyle and behavioral change. And I do want to point out that that really is the core. Lifestyle and behavior really is the core of what drives obesity. And if you look at any medical literature, you look at really if you open the drug indication package for GLP-1s like Wegovy, you're going to see that that behavior change and exercise are all part of the indication that these drugs must be used in addition to behavior and lifestyle change. So behavior and lifestyle change really applies to all BMI ranges. It's good for everyone, if you're slightly overweight or if you're morbidly obese. Lifestyle and behavioral change must be part of that equation to drive a better healthy weight. Both surgery, and I know this sounds a little bit direct, but both surgery and prescriptions, how they are effective is that they drive a forced behavior change. What they do is both surgery and prescriptions will primarily restrict your gastric intake, so less food goes in, decreases appetite, slows your digestion for some of these drugs, and decreases the hormones which stimulate hunger. So those things in turn really make you intake less. And by slowing down your digestion process, you have fewer insulin spikes. And so there's a lot of chemical things that happen as a result, but it really is a forced behavior change that helps us to achieve weight loss when we add surgery or pharmaceuticals as part of that treatment regimen. Bariatric surgery, like I said, has been around for a while. Generally, that's for folks with a BMI of 30 plus with a comorbidity, such as heart disease, severe osteoarthritis, significant sleep apnea, or BMI 35 plus. That means they're starting to get into the BMI range where significant secondary obese conditions may occur with the obesity. So that's what we call comorbid obesity or morbid obesity. So that's that BMI 35 plus range. The American Society of Metabolic and Bariatric Surgery actually has a very good comprehensive website and resource for health plans, members, physicians to look at the existing sort of landscape around bariatric surgery. So I always like to mention that website. I did link it there as well. So there's some general guidelines around what surgeries are available, which ones are the safest, which ones are not so safe or not in high utilization anymore. So really a great resource. And then again, talking about pharmaceuticals, because I think this is probably where everybody draws their attention because it's really what, in truth, is driving a lot of the cost behind trying to treat obesity within different populations. So we call those pharmaceuticals that are used to treat obesity anti-obesity medications, or you may have seen them called AOMs. So those are your Wegovy, Saxenda, those medications that are GLP-1s. And I want to point out that these drugs, yes, they have analogs that are also GLP-1s, like the specifics for diabetes. So Ozempic is kind of the GLP-1 analog of Wegovy. But they each have their own specific NDC number, and they actually have their own specific dosing regimens. So while they are the same active ingredient, they are truly two different regimens of treatment with different indications. So we're talking about Wegovy and Saxenda. Those are the GLP-1s with FDA approval for weight loss. And for those of you who don't know, and you probably all do know by now because of how much attention there's been, but GLP-1s came about from some research in the 90s in which they were looking at the Gila monster to see why does the Gila monster, the giant lizard, why does it not need to eat so often? It can eat one large meal and then not have to eat for a very long period of time and maintains a pretty healthy weight through decreased regular food intake. Well, they studied the saliva and they found this compound that is now known that was then created to be what we know now as the GLP-1 or glucose-like peptide, I believe is the GLP-1 name. So the GLP-1s were developed in that way. These medications are actually indicated for children 12 to 17 years old with a weight of at least 60 kilograms. So that's about 132 pounds. So it's indicated for adults, but also children. These two medications are. Then if we look at this newer drug called Zepbound, that includes GLP-1 and another compound called GIP. This is the newest to market, kind of has a dual action, but again, kind of drives the same forced behavior change. That medication only has an indication for an adult. So all of these medications have adult indications for BMI of 27 plus with a related condition. And those related conditions could be hypertension, really heart disease, sleep apnea. There's quite a broad range of what those conditions could be. And the reason I put it in red is because if you notice from the slide before, I said that in most states, they have a population that is overweight of near 65+%. And so then when you flip to this slide, you'll see that adults with a BMI of 27 plus, which is in that overweight range, is where the indications for these drugs started. They don't actually start in the obese range, BMI 30 plus. They start down in the overweight range, closer to that 26. So you'll see that number kind of come back up in a minute. So where is our literature telling us that these GLP-1s and how do we approach weight loss comprehensively? What is medical literature telling us? Because as a physician working in the health plan industry, and even when I was in practice full time, I really went to the evidence and say, what does evidence tell us? What does it look like as these studies have been rolled out? What are we seeing? So there's kind of 5 key things that I want to point out here. One, again, we can clearly see from evidence that high intensity lifestyle modifications can lead to up to 5 to 10% loss of body weight and can reduce diabetes rates by 50% or more. But we know that if you have to stick to only high intensity lifestyle modifications, there's less long-term compliance rates when you just tell people to do that by itself. So there's lower rates of compliance when you just say, go out there and do high intensity lifestyle modification. it's not so easy to stick to it for the long term. We do know that weight loss medications are an effective tool. And notice I put tool there. That's a very specific word because they're effective when they're combined with lifestyle modification, and then they become even more effective when they're put in combination with lifestyle modification. But what's very important is that we know that when you stop medications, the effects from the medications also stop. They are forcing that behavior change while you take the medications, but when you don't take them, there is no forced change. There is no effect being given. We also know that surgical interventions have a high success rate in the short and long term, but they do have higher side effect profiles. So they also must be paired with lifestyle modification for success. You have to control your eating. You have to make sure that you're watching for side effects. There's significant issues with mineral disorders and vitamin deficiencies because you're truly changing the way the stomach can absorb food, because you are removing essentially a large portion of the stomach in the area that can be used for digestion. Those surgeries, again, like I said, typically begin around BMI 35, not down in the overweight range. They typically begin up in the obese range. That was kind of what we knew already. But then come in 2023, a very pivotal thing happened. Novo Nordisk released the very first rather long-term trial called the SELECT trial that showed that Wegovy, the GLP-1, the analog to Ozempic, reduced cardiovascular events by up to 20% in those patients with obesity that had known cardiovascular disease. And still to date, as far as I know, this is still the only extended study that I have seen and that has been published, and it is sponsored by pharma. So I do always want to point that out. That's something that we as clinicians look for, is if the evidence is pharma sponsored or if it's independent. But we do always tend to try to see independent data, but to date, this is the primary evidence is available, is sponsored by our pharmaceutical area of the healthcare industry. And then the World Health Organization came out last year and also said, new weight loss drugs will not be a silver bullet in tackling obesity, and that weight loss drugs must be used alongside a healthy diet and exercise. So I hope you're kind of seeing a trend here. The trend is that no matter where you look, you're going to continue to see lifestyle modification, behavior change to lead to success. The rest of the things are kind of pieces of the puzzle that need to be folded in when appropriate. Then another new thing happened just recently, about 3 weeks ago, very, very recently, actually March 8th. I actually put the date there. Wegovy received an additional FDA approval. That's the GLP-1, received an additional FDA approval for reduction of cardiovascular risk or cardiovascular death, heart attack, and stroke in adults with known cardiovascular disease and either obesity or overweight. And again, they even say again, Wegovy should be used in addition to a reduced calorie diet and increased physical activity to achieve this effect. So it is indicated now by the FDA for those that are obese or overweight with known cardiovascular disease to provide further risk reduction of a cardiovascular event. I'm actually going to show you some modeling based on this study in a moment. So I just want to point out that newest indication based on the SELECT trial. Also in the last couple of weeks, CMS has indicated that Part D plans would start covering Wegovy for this newest indication. And I've seen in the last week or so, the national insurers are now starting that process of addition of that coverage to the Medicare Advantage plans following that notification from CMS. Commercial plans are also right on their tails. They are now reviewing that literature, convening their pharmacy and therapeutics committees, and reviewing how we can put that criteria into a medical policy, into our PBM criteria. So commercial plans are probably pretty soon going to start following suit. What we don't know is exactly what those policy or criteria are going to be. Even we at Capital are currently reviewing that as part of our physician committee and our pharmacy committee that's called PNT to see what those criteria may be, so we can consider adding that coverage following CMS. And again, I want to point out This indication that was released for Wegovy for cardiovascular risk reduction is not a weight loss indication. This is a cardiovascular risk reduction indication. So it's not meant to give to people to solely lose weight. It's to give to people independent of any measured weight loss, just for cardiovascular risk reduction. If we look at some national coverage statistics really quick, now that we know what the components of weight loss are and where the market is, what are the major statistics that drive benefits? So lifestyle and behavior modification, I couldn't find a single commercial health plan out there that didn't cover some form of prevention through their wellness benefit. There is high variability in the treatments, though, such as dietitian visits and specific number of coaching visits, but almost all, and I would go out on a limb and say probably all, offer some kind of lifestyle and behavioral modification support through a wellness benefit. Bariatric surgery, however, is typically only standard, notice that word standard, where if you go to a commercial carrier and you say, give me your standard commercial benefit package, it's typically only standard to cover bariatric surgery where there is a state that has mandated that as an essential health benefit. Otherwise, it's optional. And so it's typically optional. Either the health plan adds it as a additional buy-up on their fully insured, so you can pay extra for that benefit, or it's an option to self-fund it as part of their benefit package, and they offer benefit support. And so you see, as I pulled this data, I wouldn't take this for the absolute truth because I pulled this list a few months ago, but you can see there's quite a few states that actually do mandate through an essential health benefit that bariatric surgery is covered. And then pharmaceutical drugs, or the AOMs as we labeled them, currently they're very limited in terms of standard coverage. I actually could not find any plans with any standard coverage. So they're typically today only administered by self-funded plans in the current market. There is a few plans that have indicated that they may offer them as part of a fully insured benefit. But now with that emerging CMS data and also some of the indication enhancement through the FDA approvals, we are going to start to see some element of GLP-1 coverage as part of the standard benefit, but again, not for obesity specifically. It's for cardiovascular risk reduction. Just using Capital Blue Cross, just to give you some perspective, Capital Blue Cross does cover on all Capital fully insured commercial health plans, nutritional therapy, and also those wellness visits, and that does include services for obesity. So just to show kind of an example of how Capital Blue Cross includes that lifestyle behavioral modification in the benefit structure. We also, again, just like the national market, bariatric surgery is not standard on any fully insured, but we do have it as an option. And I did link some things here around looking at our medical policy. You wanted to take a look at what our coverage criteria are. Pharmaceuticals, again, following the national market. We don't yet have standard coverage for anti-obesity medications. They're only today administered by our self-funded plans in the current market. But I do want to point out, again, I want to point out that Wegovy and Ozempic are not the same. When I say AOMs, I'm really talking about Wegovy, Saxenda, Zepbound. But there is standard coverage on all plans for GLP-1s indicated for diabetes, and those criteria are determined by PBM and medical policy. And again, primarily requiring that diagnosis of diabetes. And I think all national insurers are kind of following that same thing. There typically is some kind of prior auth step for the Ozempic or the other GLP-1s for diabetes to ensure that that's the right NDC being applied to the right condition. There's also some other requirements nationally through NCQA and how we collect HEDIS data. Those NDC numbers are actually very specific to how we track quality in our networks. So if a physician is prescribing Ozempic and the person doesn't have diabetes, unfortunately, that person's going to be tracked like they do have diabetes because of that NDC tag. And so then that physician may be dinged for not checking A1Cs, for doing diabetic eye exams. So it's actually kind of negative for the providers and for the health plans if they're being written off label. So that's another reason why we really try to get the right medications or the right NDCs applied to the right condition, and why there's really not a standard for the weight loss medication just yet. So again, why is there no standard? Well, there's just really no current consensus in the health plan market. Also, there's no one size fits all recommendation. The only thing that's one size fits all today is the prevention of lifestyle modification, as I mentioned. And again, not all states have essential health benefits, including bariatric surgery. There's also very extreme variability in the uptake, effectiveness, and the outcomes that we can see with some of these medications. And typically today, because of the cost of the GLP-1s and the anti-obesity medications, it's primarily driven by individual product design. So when you put all of these things together, that creates a very complicated equation for us to make it standard for all health plans and for all self-funded accounts. So Heather, do we have any questions yet before I talk about specifically the self-funded health plan impacts?
We do not have any questions yet, but if anybody does, I highly encourage you to post them in the chat.
Perfect, thank you. So when you're looking at a self-funded health plan, I really want to point out that when and if you add GLP-1s or other anti-obesity medications, there's things you're going to see. There will be higher short-term costs because you're adding a new benefit. You're adding access to something new. So there will be some higher short-term cost. And then everybody wants to ask the question, what's the ROI? When can I see an ROI on the addition of these medications? That is also not a very easy question to answer because there's a lot of variability based on the services, the uptake, turnover rate of employees. So if you're in an industry with extremely high turnover, those people taking those medications, they may not even be on the plan long enough for you to see long-term health benefits from being on the medication. But if you do have a rather stable population, there are typically lower long-term costs, including greater impact to those comorbid conditions like osteoarthritis or cardiovascular disease. But again, if you're talking about diabetes, there's probably already coverage there because most plans all cover GLP-1s if you have diabetes. So it's kind of, do you see additional benefit from the anti-obesity medications from diabetes because you already have diabetes coverage for GLP-1s? Also, I've talked to a lot of employers who say, you know what? The clinical benefit is just extra. I want to offer this because it's a very robust benefit. I want to attract the best. I want to keep the best. I have plenty of money to support my health plan. I want to promote this. I want to drive attraction, retention, productivity, competition. And I see that more common in your high earning industries, such as the legal services industry. But a lot of employers look at this and say, yeah, the medical thing, that's only one piece of it. I want to look at how robust I can make my benefits. So you have to take that into account because of the self-funded choice. There also can be, and again, kind of a difficult thing to assess, but there can be adverse selection. Would you have people switch into a health plan that has anti-obesity medication just to get that coverage? And then you may have some short-term employee turnover because of that benefit. That's less common, but I have heard that concern in the market that it could drive some amount of adverse selection, depending on what your competitors are doing, depending on what's going on in that market. If you're the only employer offering it in an entire market, there could be some adverse selection that occurs. So everybody likes to ask me, okay, if we add this medication for anti-obesity medication, we add the benefit, what is it going to cost me? And I created this model with the help of a healthcare economist a couple of years ago, and it actually still holds true today. I've actually bumped this model up against some groups that I know that cover them, and this is pretty accurate. I've pretty accurately predicted the first year spend based on this model. So you can look at some average costs for Wegovy versus Ozempic, look at how the range of expenditures you may see if you were to add this on the pharmacy side. But I do want to point out that there's no current cutoff date. So currently, when you add this therapy, there's no indication that you stop them. They stay on forever and ever and ever and ever and ever. If there's weight loss, you stay on them. There's no indication today for the anti-obesity medications to stop them. So that's something the market's also still trying to figure out. Is there a point in which you can stop them? So if you take all these things into consideration, if you look at about a 5,000 member group, total membership, and these are all adults, assume some standard overweight metrics. If you assume a low end uptake, not everybody eligible is going to take it. Assume an average cost and a standard $50 copay. A 5,000 adult member in 1 year is going to spend about $4 million. In the first couple of years per year, about $4 million a year just on GLP-1s or anti-obesity medications to treat obesity. I have taken that 5,000 number, I've cut it in half and estimated for a group half this size, and it was about 2 million. So I know that these metrics hold up to population. So it's a pretty good way to say what would that immediate cost be. But of course, this could be based on many different factors: uptake, how much you market it, how visible the benefit is, who your population is. So these are just based on some sort of generic factors. So this is just an example. There was an article produced that said that the United States basically has prices that are 10 times more than anywhere else in the entire world for these medications. And if you were to say, well, what really should the price be? Honestly, the price to really treat everybody with overweight or obesity just based on that, no other clinical risk factors, a more cost-effective number probably is about $200 per month, not the $1,200. So hopefully with some of these growing indications for clinical indications, the market's going to drive these costs down to a much more affordable range. My fingers are crossed, because as I said, there are benefits, but at the $1,200 price tag, it can be quite a sticker shock and quite an impact to employers to add this coverage. There was also a case study done that looked at the cost benefit based on the SELECT trial. So there was this article I've linked that said that Novo's Wegovy prevents heart attacks, but at a cost. And so this study showed that to get that cardiovascular risk reduction, you would need to treat 60 people for 3 years consistently. All 60 people consistently taking the medication for 3 full years. That means they stay on the health plan, they stay taking the medication. And if there was a discount, that employer would have to spend about $1 million to prevent one cardiovascular event. So there is benefit, but at that current price tag, it is a significant cost. And you would need to see quite a lot of persistence and compliance on the treatment regimen. Let's see, I think I have a question. Oh, we have a question. Heather?
Yes, we have a question. If a member is prescribed Wegovy for cardiovascular risk reduction and the member loses weight and let's say does not have sleep apnea anymore or hypertension, does the provider then stop prescribing it for CRR? And then they wanted to clarify, this person is non-diabetic.
It's a really great question. That's what I was pointing out. We don't know yet. Unfortunately, none of those criteria have been developed. The research is so new that insurers, even Medicare, is now currently compiling those recommendations of how that medication should be applied. I can guess, and I'm going to tell you, just like today, if I have cardiovascular risk and I take a statin, like lovastatin, simvastatin, like a cholesterol medicine to reduce my risk, technically I should stay on that forever. Even though my cholesterol may come to normal, even though my numbers may look better, for the risk reduction benefit, I should probably take it forever. We think that same thing is going to happen with the GLP-1 indication for the risk reduction as well. Once you reach a threshold for having significant risk, essentially you're a candidate for that medication forever. That's where we think it's headed, but we don't know yet. We're going to have to see what CMS comes out with in terms of their policy coverage, their terms, and then we're going to kind of have to see what insurers come out with. And then remember, there's only that one study. We need more studies. So I fully expect that to continue to evolve and us to get more information. But those are the exact questions everybody's asking. That's the question I, as a physician, am asking. If we put these members on these drugs, when would be the appropriate time to stop them? And honestly, we don't know yet. So that's a really great question that I think everybody's asking. I'm not going to go over this one too much, but these are just some benefit considerations as you're looking at a comprehensive benefit, thinking about narrow versus comprehensive, the cost sharing. Typically, there's some combination of a metabolic specialist within these benefit structures if you look at very robust benefits. I did put in some samples of common obesity benefits that you could read through, but there's just different ways they can be worded and structured. Pharmaceuticals, really, they're either not available or they're available. And then it's often driven by the FDA approval or a specific PA process. And I just would point out that typically, if your pharmacy's carved out, it's typically more difficult to say there's a medical requirement, like you have to be part of a weight loss medical program to get your medication, because then you're mixing medical benefit and pharmacy benefit. So if you have a carved out PBM, it's harder to make your pharmaceutical PA requirements more complex. They have to stay rather simple and within the PBM. So just some nuances there that I wanted to point out when considering what benefits you may want to put in place. This is a very big slide, but this is what I call a refrigerator slide. I could print this out and put it on the refrigerator, and honestly, I could follow it for a lot of different things, not just for obesity. But these are things you should always be asking when you're considering adding a new benefit, changing a benefit. This one is geared around obesity and overweight, but really it's pretty simple. It's know your demographics. Who are you dealing with? What's your turnover? What's the demand? Know your current benefit. What are your current structures, limits, and what would the impacts be if there were changes? Would you be an outlier? Create a draft, determine your acceptable short and long-term cost absorption. That'll help you to determine cost sharing elements. That'll help you determine what elements you may want to add, remove, and then use every piece of data you can get your hands on. You're going to have your plan administrator, your PBM, your TPA, broker, pharma, anything you can get a hold of. I would ask for those resources. Take advantage of those market cost estimation models, but really look at the components that are being added. And you want to include your services and cost share in your benefit criteria, and you may need clinical criteria within the benefit itself if your plan administrator doesn't have them. Capital has a whole policy around bariatric surgery, for example. Some carriers don't have a standard medical benefit, so I have seen some health plans, some self-funded plans, create their own benefit within their benefit package, within their coverage benefit statement. And so they actually put the criteria in there if there's no medical policy. But a lot of carriers now have their own medical policies you can use. I know we're talking about a great topic there, but I do want to touch base on another big topic real quick: gene and cell therapies. Why are these so important, and why do you hear about them so much? Well, they are also high-cost therapies, and they can have also significant impacts on self-funded health plans. What are they? Well, these are therapies that treat, prevent, or potentially cure diseases through a biologic process, or called a biomedical therapy. The key here is they have the potential to remedy the underlying cause of genetic and acquired disease. Really the first of their kind. There's not many other medications out there that you can say can truly cure a disease, besides antibiotics for infection, but there's very few of these medications out there that can truly cure a disease. You're typically treating symptoms or you're controlling a disease, but these can provide remedies and cures. Cell therapies are basically when you take a cell from inside the body, a biologic cell, and then there's something that cell is targeting. Like let's say it's an infection cell. So today we have T cells that are targeting infection cells, and they have receptors. So that receptor is going around looking for that bacteria. If it finds it, it attaches to it. Then it says, hey, you need to destroy this thing. And then it attacks it and destroys it. We can actually then take those little receptors off the T cells, modify them, give them new receptors to look for new things. And one of those new things is cancer. So this new thing may be cancer floating around. And so now those receptors are looking for cancer. And when they find cancer, they attach and they kill it, or they destroy it. So modified T cells are a very good example of cell therapies. Gene therapies, however, actually use something like a transport mechanism. So you can imagine a car carrying a delivery truck delivering a payload inside the body, and trying to deliver something into the genetic material. So what delivers things into genetic material today, without gene therapies, are actually viruses. So viruses like the herpes virus and other viruses actually have the ability to go in and attach to our DNA. So by taking some of those viruses, pulling out the viral payload, pulling out the viral delivery package, and putting in a new package, so beneficial genes, beneficial things, now that delivery truck can go inside the body, attach to the DNA, and deliver good stuff, change our genetic material actually, so that now our genes are working functionally where there was previously a dysfunction. So those gene therapies actually replace, introduce, or inactivate specific genes causing a problem through those viral vectors or payloads. And typically, these are infused and injected therapies, both cell and gene. So today, all that I know of are covered on the medical benefit because they are injectables. They are infused. So these are often considered medical specialty drugs. So let's talk about gene therapies because they typically cause the most talk in the media. The pros and cons of gene therapies are that they're potentially curative, which is quite shocking that they can cure very severe and rare diseases. They're often a single treatment. You only get it one time and then it's cured. That's it. That's all you need. Yes, it's very expensive, but that's it. You're cured. You don't need further treatment. I'm going to talk a minute because that can actually sometimes be a con. But gene therapies can also have generational curative effects. Think about that. If I have a problem that's within my genetic material that I could then pass on to my children, some of these gene therapies can go in and fix my genetic material, including my the sex genes, that if I had children after receiving the genetic treatment, my children wouldn't have that risk. So it can actually have generational curative effects in some cases. The cons, though, much like cell therapy, is that it's very expensive at the outset, but it can replace long-term therapies and long-term spending. It's still relatively new, and there's still a lot we don't know. So that includes things like, could I unintentionally pass something to my children that I maybe don't need to? Maybe it would alter their genes too much. We don't know yet. There's also a lot of talk around the ethical impacts of genetic modification and where do we stop? Where do we stop this? If we can go so far, how far can we go? There's also now some emerging data that shows that if I get gene therapy once, and let's say it uses an element of the herpes virus, that herpes virus carries that new genetic material into my genes, I could actually develop an immunity against that virus. And so that if I ever were to be a candidate again for gene therapy later that also used the herpes virus vector, I wouldn't be able to get it. I've then basically used my only chance in my lifetime to be able to get that treatment. That gets a little complex because not all gene therapies use the same virus as the vector, but there's a lot of commonalities. So all of these things are still being considered. So everybody who is a candidate for gene therapy doesn't always end up getting gene therapy for a number of these reasons. And when you look at how does my health plan support me as my members may become eligible for gene and cell therapy, I call these the 4 pillars of support. These are the 4 pillars of support you should always be looking for from your health plan and from your carrier around gene and cell therapy. You need clinical quality and appropriateness guidelines. There must be medical policies in place to ensure that these medications and these therapies are being given for the right conditions at the right time for the right people. You also want to make sure that the plan is having some kind of process for ongoing pipeline analysis and review of literature, because these indications are growing hand over foot. There's more and more gene therapies and cell therapies coming out every day. You want to look for pharmacy and pop health support. These medications can sometimes be given in varying doses, varying volumes. There's a lot of dispensing kind of limitations around some of these medications. You need very strong member support. Not every hospital healthcare system administers cell and gene therapy. So you need very strong member support to make sure they're going to the right place, make sure they're going to follow up after they get the therapy, make sure they have all the resources they need, because the last thing you would need is if somebody qualifies for this therapy, they get it, and then they don't follow through, or they do something, they leave the area, and then they have a side effect, or they don't follow the recommended post-care regimen, or something happens, and then that causes that failure treatment or that causes that treatment regimen to fail. So then you're dealing with, well, we got it, we paid for it, but it actually failed, or something happened, or the member had a worse outcome. So you really want very strong member support, education around the importance of the medication. And really, you also want to try to take a look at what members within your plan may be candidates for these. So if you have specific cancers being reported in your health plan, knowing which ones of those may be candidates for cell or gene therapies, just so you can plan ahead and think about any possible cost exposures. You need some element of network and provider partnership. Health plans typically also have very strong provider partnerships. Within the Blue Cross system, we do rely a lot on the Blue Distinction Centers that are supported through the Blue Cross Association. Today, there's a network of cell therapy high quality centers, but there's only one gene therapy center, and that's around the ocular therapy. So those are still being built out. The other thing I mentioned, like I said before, there's very few places that will even carry the medications, administer the medications. So you really need to know exactly where those options exist for your membership. Make sure you've got a good structure to support those members if they were to need to go to those places. And then lastly, stop loss. Because these are high cost therapies, there's a multitude of stop loss options out in the market. Some health plans offer unique stop loss arrangements for cell and gene therapy coverage, but you need to make sure that the stop loss is basically right for your population. Of course, everyone's trying to avoid lasers, and you want to make sure that you take a look at what the funding model is. Is there what's the maximum exposure to the group? So really looking at these 4 pillars of support, and make sure you have all of these things in place to really understand what you have in each of these categories, so that when you do, and I think it's really not a matter of if, it's a matter of when. If you run a health plan long enough, you will have somebody that becomes a candidate for either cell or gene therapy. And you want to make sure that you really understand the support within all of these categories that you have in place to support yourself and the member. Any questions about that? I know we're covering so much information, but these are complicated topics, and I want to make sure I give you some good pearls of information to take away to your day-to-day work.
No questions yet on that section.
Perfect. I am going to jump quickly to gender affirming care. Another topic that has been quite evident in the media as of late. I get questions on this a lot. We see a lot of questions on this when we get requests for proposals for new clients. They want to know what we're doing to support gender affirming care. So I do want to talk a little bit about the review of the clinical basis for coverage of gender affirming care, and really where the market is in terms of evolution, because there is still some changing things in the market to be aware of when you're looking at these benefits. First, what is gender affirming care? I think probably when I say gender affirming care, most people tend to think first about surgery. And it's actually not only surgery. Surgery can sometimes be a piece of that equation, but it's not always, and it's not the first. So the Kaiser Family Foundation defines this, and I think this is a pretty well accepted definition. This is social, psychological, behavioral, and I'd probably put and instead of or medical, because typically it's all of it. Medical, including hormonal treatment or surgery, all those kind of interventions designed to support and affirm an individual's gender identity. And that is most often associated with a condition known as gender dysphoria, which is defined in medical literature and within medical textbooks. There's one called the DSM. That's our diagnostic manual for behavioral or psychological conditions. So gender dysphoria in that text is defined as the feeling or discomfort or distress that might occur in people whose gender differs from their assigned sex at birth or their sex-related physical characteristics. So again, that is a defined medical diagnosis. And I want to point out that we're talking about two different things here. Gender, which is really honestly a bit of a social construct. We as a society define what males and females, how they should dress, how they should act, how they should look, hair length, makeup, no makeup, jewelry. All of that is rather a social construct. And our clothing, all of that. A person's sex is based on genetic material and their genitals, the genitalia. So there are actually people that are genetically male that have an X and Y chromosome, but are born not with male genitalia. They're actually born with female genitalia. There's a condition called testicular it's called a testicular desensitization syndrome, I believe, in which you can have male sex hormones, but sex genes, but you have female genitalia. So there is a difference in gender and sex at the scientific level. And so gender is how we identify as male or female outwardly. So gender dysphoria is if I, Jeremy, am expected to be male, but I have discomfort with that, and I really feel like I'm intended to be female, that's how I want to live is as a female. And it causes me quite a lot of distress, and that must be diagnosed by a medical professional. So the federal government and the states have gotten involved. Now, this is where it gets complex. Most all national medical organizations support providing both pediatric and adult patients with gender dysphoria and gender affirming care. So those with gender dysphoria, providing them gender affirming care. And keep in mind, that does not always mean surgery. It means all the other stuff as well. So nationally, both adults and pediatrics are supported. The current presidential administration also fully supports gender affirming care for both adults and pediatric patients. Almost all major insurance carriers provide some coverage for gender affirming care as a standard benefit for their fully insured populations. And what you're going to see is that there's where we start to differ with pediatric and adult. So I'm going to talk about that in a second, because many states, several, have current bans on gender affirming care, very specifically surgery for children and adolescents or teenagers. But self-funded accounts have the ability to restrict benefits for providing gender affirming care. But there's also been some national news in which some non-ERISA groups have been the focus of litigation because they're essentially government supported agencies, but they have tried to elect to not cover gender affirming care. So there has been some litigation publicized around those groups. So you can see there's some disconnect between the national environment and the state and local environments. There is a professional association for transgender health called WPATH, in which they do offer standards of care for health plan providers. This is what Capital Blue Cross follows. We get this question in RFP all the time. Do you follow WPATH standards? Show us how you follow WPATH. But it provides direction on healthcare coverage needed by transgender and gender diverse individuals in the following area. And you can see it's all of the areas that may constitute gender affirming care to promote that patient's health and well-being. And so again, compliance with those WPATH standards is becoming a frequent question on national RFPs and really has become our standard language behind how do we make sure we're covering gender affirming care comprehensively. And we're currently at version 7, but we do expect them to continue to update these criteria. And those are publicly available, but I did link that as well into this PowerPoint. Good news is plan administrators offer a lot of support, but I'm going to point out some include pediatric criteria and some do not. Mostly that is because of those state and local variations from federal guidance. So you'll see the Capital Blue Cross, we actually don't have pediatric criteria. I believe that Aetna may have some of both. So I would encourage you to take a look at what's available with your own carrier within their medical policy, just so you're familiar with what coverage criteria is made available. So in the end, self-funded plan guidance, check your state laws and your regulations, know your population. Again, if you have a population with a significantly diverse population, you have employees that are that have children that may have some of these gender identity disorders, you would really want to make sure you know who your population is, where the state that you're in, the regulations, and really strongly consider your position in diversity, equity, inclusion, and what those priorities are as a company. They can be different. Consult with your plan administrator and consultants to determine what your standard benefit is. I've talked to some health plans, self-funded, and they don't really even know. They don't even know there's a medical policy. They don't understand how their current benefits supported today. So I would encourage you answering that question if you don't already know, because if you want to modify them, that may require custom benefits. It may require exclusions. It could require a custom medical policy. There could be some significant work if you wish to alter some of that standard coverage. And again, I want to point out that today, in today's market, exclusion of gender affirming care is neither recommended in the health plan industry, it's not recommended in the healthcare industry, because there is significant clinical evidence that there is benefit to these patients that have gender dysphoria and receiving gender affirming care. And also there is significant disruption in the national environment. I did throw in some additional resources. These are primarily around anti-obesity medications, but those are some resources to link that you could take a look at. And that's it. And I think I made it with 2 minutes to spare. So if there was any questions about that extremely complicated information and that ton of information that I shared, please let me know in the chat.
No questions just yet, but people may be typing them.
Sure, I'll give a second. And we will be making this material available afterwards. Heather's going to go over that in a second. So if you need a little time to digest, totally understandable, want to take a look at this afterwards, that is totally acceptable. And please use these as reference. Use this material as reference moving forward.
We do have one now.
Okay, sure. Let's go.
Any opinion on the CAS report that came out of the UK yesterday, if that will affect the recommendations here in the US?
That's a great question. I haven't seen it. So I didn't see it, but I'm going to go look for it now. So I appreciate you alerting me to it. Typically, I'm about 2 days behind on national news because I tend to stay quite busy with my day-to-day, but I'm writing it down now to go take a look.
Excellent. Another one came in. Can you define a GLP-1 medication?
Can you define it? Yes, and I do believe I got the acronym wrong. I always get my acronyms wrong when I'm talking about pharmaceuticals. It's glucagon-like peptide is GLP-1. And so I can define them. It is a medication that works in a very specific way. So GLP-1 is the class of medication. They are designated as GLP-1. So if you look up Wegovy or you look up Ozempic or Saxenda, those brand names, and you go to their mechanism of action portion of their drug document, the package insert, it's going to say they act on GLP-1 receptors. So that is the mechanism of how those drugs work. So that's why they're called GLP-1s. And so we can define them. And as I said, they have their own specific NDC numbers. So many health plans track utilization of these specific medications. NCQA tracks who gets prescriptions for these medications under health plan coverage. Because if you're getting a GLP-1 brand type of medication for diabetes, then those people are expected to have their diabetic eye exams, their diabetic foot exams, their A1Cs checked, all of that regular care for diabetes. So it's very important to know which GLP-1 medication applies to which condition. And they have specific FDA approvals for those.
Excellent. And it's so interesting that it came from, you said saliva? Never knew that.
Oh yeah, it was due to study from saliva of the Gila monster. So sometimes, like any medication, not all medications are right for everyone. And so I say, what may be right for all Gila monsters may not be right for all of us. So just because all Gila monsters have it doesn't mean it's right for all of us. And as more people have taken these GLP-1s, what I didn't mention was that we're learning more and more about side effects. As more people take them, the more we learn about them. So we're also starting to learn more about the negative effects of long-term GLP-1 use, not just the good effects. So lots to keep an eye out for.
Interesting. Yeah. I think we have time for one more question. Any thoughts on self-funded medical plan covering Wegovy and not Ozempic? Ours only covers Wegovy for diabetics. Should we consider Ozempic as well?
So I suspect, and I'm just guessing, I suspect you may have them backwards. Ozempic is actually FDA approved only for diabetes treatment, diabetes type 2, not even type 1, just type 2 diabetes. Wegovy is the same active ingredient, semaglutide, but it's formulated and dosed in a specific way to treat obesity, and it has an FDA approval for that. So Ozempic for diabetes, Wegovy for weight loss. They had two different dosing regimens for two different indications, just the same active ingredient. So I would definitely go back and take a look at your benefits, because I think you probably are covering Ozempic for diabetes treatment and maybe just not Wegovy for weight loss. But I will, again, want to remind folks that we're going to start to see increased FDA approval and increased FDA indications for Wegovy beyond obesity, including the cardiovascular risk reduction. But you could cover both. You could cover one or the other. I actually don't know any health plans that don't cover Ozempic for diabetes. I think it would be extremely difficult and ill-advised to start excluding diabetes treatments, especially ones like Ozempic that have significant health benefits, reduced A1Cs, reduced cardiovascular risk. That literature is extremely well developed, lots of long-term data for diabetes. So I would say, the ability to exclude Ozempic for diabetes would be very, very difficult. But excluding it for weight loss is easy because there's no FDA approved indication for it. There's no NDC for that. There just is for Wegovy.